सैंपल वाले अपना भी फोटो चालू होगी ना मीटिंग जैसा कि क्या बोला कुछ बोला तुम क्या नाम है गए थे ना
हेलो हेलो
एक बार एक बार फोटो देखो
अभी क्यों ना
हाँ जी विकास सर। हाँ जी नमस्कार सर। am I audible? Hello. Uh, Hello. Can somebody confirm? Miss Palak, are you there? Oh, thank you very much. Thank you very much, Jyoti Lakshmi ma'am. Highly appreciated. So we will be starting our session shortly. So I'm making you co-host. Good evening, sir.
Good evening. Good evening. Yes.
Yeah. So before you start, I really wanted to talk to our participants, at least for a minute, if you allow me.
Please, please.
Yeah. So first of all, thank you very much and namaste to all of you. Thanks for the second series of our program, the Mass Casualty Management for Nurses. This is based on WHO Academy program. So we try to design it in a very hush-hush manner. So commonly everybody is asking one question, are we going to get the certificate out of this program? So let me tell you, ma'am and sir, thank you very much for attending this series. First of all, this is just a series. Certificate is something which is having a huge credit. And as a WHO collaborating center for emergency and trauma care from the Department of Emergency, Jayaprakash Narayan Trauma Center, AIMS, New Delhi, we are not and we discourage to give certificate just by attending online sessions. But definitely, we really appreciate your time, your energy, your efforts of self learning, and we are working hard. Our team is working hard to designing these session, coming to you and upgrading. And as you all know that our nation, our country needs us. So at this point of time, I think certificate having a lesser, value than upgrading ourselves, because at the time of need, we all need to be trained for the mass casualty management. So with that, I hope all of you as a nurses, because every time, and this month is specifically for the nurses, this is time to give back to our nation, and definitely we nurses always at front foot to give back to the nation, as we were so much celebrated during the COVID, and this time again we should upgrade ourselves and be ready if we needed in case of any mass casualty. With that, I request my WHO Collaborating Center Co-Director, Dr. Tej Prakash Sinha. He will be taking today's session on triage. But this triage is at the time of peace when we are in regular emergency. So today we are going to discuss triage in emergency department. And as I said, the certificate, definitely we are working hard to give you certificate, but this certificate would not be just by attending the session, but definitely the participant who will be attending our series of session, and if they attend more than 80%, so we are trying to give them online questions, and based on the online question, this assessment, if they score more than 70-80%, they will be getting certificate. But at the same time, we have already applied to the competent authority to get that the credit are for this certificate. So soon we are coming it as a course, formal course for mass management, for mass casualty management course for the nurses. At that point of time, definitely it would be a certificate course. But I request everyone, please, this time country needs you, and it is a high time that we should give back to our country. Thank you very much, and over to you, sir.
Thank you, Rupa, and thanks all for joining us. So, do they need to register again, Rupa, so that they can make their attendance?
Yes, sir. During your session, I will be posting that registration form.
So, please, all of you note that probably in every lecture, we have to just sign in again so that the attendance can be moved. Okay, so thank you, and thanks again for joining in large number. And I know that many people are preparing themselves. And just after last class, we saw that in MP, And in few more places, we got the pictures, videos by posted by them to us that after the overview class, they have done some kind of work at their own place, preparing for mass casualty management at their hospitals. So that is very, very, I should say it is a heartwarming response by all of you. So welcome back for this very important topic which we require in day-to-day life. That is the triage. Triage. So by this time, I fully aware that most of you or almost all of you are aware about the triage. So let's go a bit detail about the triage. This triage, what we are taking today or discussing today, is about emergency department triage. When a patient reaches emergency department and we do the triage, and this triage is fully done by, or you can say the nurses are the pivot of the triage system at any hospital. So this is a nurse-led system. So let's move forward. I'm Dr. Tej Prakash, work as additional professor in Department of Emergency Medicine, AIIMS, New Delhi. And today we will discuss about emergency department based triage or ED triage. So I will request that,
Sir,
yes.
I'm so sorry I'm interrupting you. There is a big black color, one rectangle, two rectangles on your screen. Can you withdraw your screen and share again, sir? That obstructing the view, sir. Yes, sir, it's much better. Thank you very much, sir.
That's fine.
Yes, sir. Yes, sir.
So take some a small piece of paper and pen and just you take this small test before we start and keep the answers paper with you so that we can go ahead in at the end. Okay. So just mark number 1, 2, 3, 4 like that, and then whatever best choice you feel, you have to mark in front of one best choice, suppose A, B, or something. Okay, and you just write on top of it is pre-test. Okay, go ahead. Let's move forward. So first question number 1. Okay, so what do you mean by triage? Just write in front of one best answer. Please take care of your cursor, Sarika, Divya, Vani. Your cursors are moving. Don't mark here. Don't mark here. You just take one paper and write your answer on one paper, not on the screen. Don't go on the screen, please. Don't go on the screen, please. No need to go on the screen, please. Sarika, please take care of your cursor.
Sir, I'm just trying to control it. Just need a minute.
I just take care on the
Yeah.
participant side. I am
Yes.
requesting. No need to message for this. You take out one paper, small paper, write your own answers and keep with you. No need to message here. Okay, take out one paper. Okay, no need to answer here as message. Okay, you just keep with you. Let's move forward. 1 plus, see, just take care of your cursor, please. No need to mark, please. Okay. It will be very difficult. Okay. Just I'm resharing my slides. Participant, please take care of your cursor. Okay, question number 2. Just write question number 2 on a plain paper and mention your answer on your paper. Don't write in the message. Okay. Best answer, please. Just write on your paper. Question number 3, triage system was first time practiced in, these are the answers. Write on a plain paper. Keep a plain paper with you. Write the question number and just mark A, B, C or D, whatever best single answer you think. Question number 4. Question number 5. Question number 6. Question number 7. Question number 8. Question number 9. Question number 10. Okay, so just going once again, if somebody has not seen the questions, question number 1, best answer out of ABCD. Question number 2. Question number 3. Question number 4. Question 5. 6. 7. 8. 9. 10. Okay, so so keep the answers and the paper with you, and we will revisit these questions at the end. Okay. So triage, in this particular topic, what we mean is triage at emergency department in day-to-day practice. Okay. Sorry. Not about the mass casualty right now. Day-to-day practice. Triage in day-to-day practice in emergency unit or emergency room or emergency department, also called older name casualty. We'll try to know about the triage, what this triage means, what it is, a bit of background, and then more importantly about the various categorization under triage and how we deal with those various categories, aligning with the various areas. So these are the things which we are going to cover in next 45-50 minutes. Okay. So the triage means to sort or to choose. It's a word derived from the French word trier. So in this particular triage activity, or we just try to categorize the patient or sort out those patients who require the treatment first. So based on the severity or urgency of care they require. Okay. So to sort out, to categorize is simply is the meaning of the triage. Okay. So this was all when the this was utilized first, and you can say practiced during the wars. Okay, early 80s, and mostly these terms we use, or earlier it was used for the war zone, and then later on for disasters. And these were the two gentlemen who started the pre-hospital care, actually, the ambulance concept of flying car. This a French military surgeon with Napoleon in Egypt. So they started this flying car concept when the soldier used to get injured. So they used to categorize them in those who can still fight, those who are severely injured, cannot fight, and if given treatment, they can return back and fight. So that those were the criteria which they utilized during the wartime. And slowly, the system, what they utilized, categorization system, they utilized was able to save more and more soldiers and continue with the fight after just a small treatments to those who are injured. So this is actually started there during this wartime. Okay. So it evolved slowly. It evolved from the war period, and then later on during disasters and yeah, many that kind of scenarios where large number of people got uh, involved. So this slowly went ahead with from the war to disasters and got matured. So overall, the idea of doing this kind of categorization is to match your resources with the demand. That means the right person or the right patient can get the treatment by right people in right place. Right place means whatever is the requirement of that patient is available in that area, be it human expertise, be it the resources otherwise. Okay. So that's why I say these are the rights which this triage used to sync. So right patient in right place in right time by right people, treated by right people, and it is validated as the right regions also. So this is the overall goal of the triage, is to get the treatment early to the sickest, followed by those who are comparatively lesser sick. So categorization, sorting out. Okay. So triage. So triage is globally it is being used in emergencies, and few of the very notable triage systems are ESI triage system, so emergency severity index triage system, then Canadian triage system, Manchester triage system, Australasian triage system. So these are the globally renowned emergency department based triage system. So almost 16 years back, we started trauma center aims came in inception in 2005-6, and then slowly the treatment started, and we started taking patient in 2007 end. And initially everything was common like other hospitals, but slowly we came up with an idea that whatever we are receiving the patients, we need to categorize in some or other way. And we developed a protocol for triage in emergency department, what we called as AIMS triage protocol. with a simple thought process from the traffic light, red, yellow, green, three concepts. So this triage system we implemented at our place. We found some usefulness, and then we published also in pre-hospital disaster medicine journal, and followed by implementation in on wide scale, and then knowing about the nitty-gritties and doing the quality improvement. So slowly it developed at our place, and slowly we moved ahead, training others. And now you will be very happy to know that the same STRICE protocol is being taken up by Ministry of Health, and it is part of the district hospital operational guidelines, the primary and secondary care guidelines, even in the Niti Aayog document. And we have a full-scale AIMS TRIAGE protocol training. So National TRIAGE program where we teach and train triage also. And very important fact of this TRIAGE protocol is it is nurse-led. Even the course is nurse-led. So thanks to our nurses that they have given me chance to interact with you. So thank you all nurses. Just few days after the Nurses Day. Thank you very much. So let's move ahead. So as I told that it is mainly earlier practiced in the disaster setting, and slowly it came to those crowded EDs, and now it is a norm. Okay, now it is a norm. So the in disaster, what is the overall idea in disaster is to provide most effective care, not the best one, not the best one, to maximum number. Greatest good to greatest number. But in day-to-day practice, what we try to provide best of the care to each one of them. So that is in day-to-day practice. Okay, and thanks to this great lady. So Florence Nightingale, the founder of modern nursing, and she was the first trauma nurse, the first nurse who presented the data in a great way. So all accolades and great nurses we have. Right now also a lot of great nurses we have. So thanks to Florence Nightingale to bring this very unique thing to the world. So our triage system is derived, I told that it is derived, or the conceptually we matched with the traffic light, because every people knows about the traffic light. It is very simple to percolate. If you see the ESI system or other triage system which is being used globally, they have a 5-tier system, category 1 to category 5, which is very difficult to remember at our place. So we thought, why not to go with a simple one, traffic light. So red, serious. Green, free, you can go. Okay. Yellow, something. Maybe some problem, may not be some problem, maybe sick, can become sick, maybe very simple. So all doubtful. So red, yellow, and green, these 3 broad categories. The 4th one is black. Usually, we don't give any black category in emergency department in day-to-day practice. See, always remember, I'm reminding you, this is nothing about mass casualty. We are discussing about the day-to-day triage. Then only we can learn about the mass casualty triage. Okay, so red, yellow, green, and black. So right now, in day-to-day practice, we label somebody black if there is contraindication of CPR. That means if somebody came beheaded, there is no head, so we cannot do CPR. So it is already known it is a dead one. Okay. Mutilated body. These two are the real contraindication for CPR, mutilated body, and beheaded. The third, you can say, not the absolute contraindication, but you can say it can be a contraindication is rigor mortis. Because there may be some differential of rigor mortis, like pugilistic attitude, or maybe electrocuted patient, maybe patient with contractures. So you may get confused. So, but yes, if you are certain that the rigor mortis is set in, then it's again black. Okay. Otherwise, you have to make either red, yellow, or green. So these 3 color codes we will remember from now onward: red, yellow, and green. So 3 color system for triage. Okay. And idea is to match the demand of these patients. So in emergency department, we create similar kind of areas. Similar kind of areas means red patient is the sickest one, yellow patient is the middle one, and green is very simple. Okay. So based on the need of those sickest patient, we create one area which can address the demand of that kind of patient. Like in trauma, who will be green? The small, minor injuries, okay, small things. So we just require dressing, pain management, and maybe some splinting, soft tissue injury, those kind of things. Maybe tetanus toxoid or those kind of things. So they can sit, they can walk, they can be on wheelchair. So you can see on right side, this is the green area. Most of the patient are here in wheelchair. And on back side of this is the picture of our old emergency department. Now it is renovated. So this side multiple chairs were kept. So this is for green. And whatever requirement is there, they can just avail the requirement. If I talk about the resuscitation area or red area, what we require? We require all sort of gadgets. You can see monitor here. Then we used to keep the ventilator, defibrillator. You can see the portable X-ray machine here. You can see some lights, OT lights are here on top so that you can do some procedure also. So oxygen, suction, intubation, crash cart, light, ventilator, defibrillator, everything is kept here. All high kind of drugs. Okay. In yellow, what we require? These patients right now is good, may deteriorate. Right now is not that great, but can improve and can be discharged. So we require some kind of monitoring devices and some support system, basic support system. That means the oxygen, suction, monitoring, provision for IV fluid, like here you can see hanging from top. So those kind of things. So we create areas also as per the need of the patient. Okay. So triage category red, yellow, green. So the areas, red, yellow, green areas. Apart from this, we keep separate area for dead bodies. So that we can label as area for black patient. But for working, these are the 3 working areas, red, yellow, green. Okay. Okay. So, so see now coming to how we do triage. So again, taking you to the basic concept, any patient in whom you feel life, organ or limb threatening, we label them as a red triage patient. Red means resuscitation requiring patient. Resuscitation means life-saving procedures, limb-saving procedures, organ-saving things. Okay. So any patient where life, organ or limb is threatened is red category. Any patient whom you think is having a very minor kind of thing and there is no need to keep, observe, investigate, just do minimal thing and can be discharged safely, and there is no adverse effect after that, any major adverse effect, that is green. And the third one is where you want to check, like a person is saying, I got electrocuted at my home. I don't know how much, but I was having nothing, no symptom, but I got electrocuted. So I am having nothing, no problem. So you want to observe them. You want to do some investigation if you doubt. Like you want to check the ECG, rhythm theek hai ki nahi hai, what kind of thing. So that is yellow category. That is yellow category. If everything is fine, but still you want to observe them. A patient who comes with a snake bite, he don't know poisonous, non-poisonous, everything is fine. There is no local symptom, no systemic symptom, clinically absolutely fine, but still you want to observe. That is yellow. Okay. So meaning to say, any patient whom you want to observe or investigate or do both is yellow. So life, limb, organ threatening, red. Minor, no need of observation or investigation, green. Those where you want to do something, not so sick, not very simple, yellow. Okay. So let's go forward and see how we do the triage. What are the basis of doing the triage? What are the criteria on which we go ahead with the triaging? So today we will take in detail about the triage for trauma patients. Okay. And at the end, I will tell you about how to utilize the same triage protocol for non-trauma cases also. Okay. So be it non-trauma or trauma, the first and foremost important criteria is physiology. If physiology is fine, the patient is not going to die. Okay, so let's see how we know that this patient's physiology is normal or abnormal. So what do we follow? We follow simple way to assess the physiology. One is just ask name. भैया क्या नाम है आपका? माता जी क्या नाम है आपका? मैडम क्या नाम है आपका? क्या हो गया? चोट लग गई? So if that person answers you at हाँ मेरा नाम मोहन कुमार है, नहीं गिर गए थे, थोड़ा चोट लग गया है. So if somebody is able to vocalize and telling the name, you ask the name, he is telling the name, that means his brain is functioning, his voice is coming, and he is having enough reserve so that he can vocalize. That means the airway is clear, then only he can speak. He is having good reserve inside the chest, lung reserve, then only he can vocalize. So airway is fine, P is fine. And you ask the name and he is telling the name. That means brain is functioning. Brain can only function if the brain cells are getting the oxygen and glucose in timely manner. And they can get oxygen and glucose properly if the blood is reaching to the brain in a proper way. That means circulation is fine. And you ask the name, he answers the name. That means the brain is also functioning. So this is the quick, simple way of triage knowing the physiology. So just asking the name. So 10-second way to know the physiology is right or not. So ask the name. If he or she is telling the name, he is not going to die right now. He may deteriorate, he may improve, doesn't matter. But right now, this is a quick, simple way to know the physiology. Next is how we can know about the physiology in detail. Okay. So let's go in some detail. Before that, we'll take one question. So a 25-year-old male having history of road traffic injury came walking and talking. So just by it, what will be the triage category? So just by that, you told he is not red. His physiology is fine. Okay, so just by listening this much or getting this much information, we can say his physiology seems fine right now. Okay, this is a broad way to address the physiology. Now, taking some more information further. So now we are monitoring the vitals. So his heart rate is 148 and BP is 84 millimeters of mercury. So now what you say? The BP is normal, heart rate is normal, yes or no? It is not. It is not normal. So now, just by physiology, just by asking name, we cannot say with that confidence that everything is fine. So now we are going for ABCD assessment in detail. Okay. So another scenario is having 45-year-old male in unconscious state with gurgling sound. Okay. Blood pressure is 110/78. Heart rate is a bit up. GCS, you can see it is 8. So again, unconscious, gurgling sound, GCS is low. We are not going to label them as green. Okay. So if the ABCD is compromised, like in this patient, you can see gurgling sound, unconscious, airway is threatened. So anything out of ABCD is compromised, we call them as red. Yellow or green, stable ABCD, maybe yellow, maybe green. So if somebody is having moderate injury, yellow, mild injury, green. So that means we have to further go in detail about the types of injuries or where they get injured. So let's move ahead with the ABCD assessment. When we will say that in airway assessment, he is having the criteria which is fitting with red. So like in airway, we say airway is patent, that means everything is fine, or it is compromised, or it is threatened. So in unconscious patient, tongue used to fall. So this is a compromised one. Severe shock, they cannot maintain the things. So it is again compromised. Maxillofacial trauma, okay, compromised. And there are certain things where it is right now the airway is patent, but patency can be lost at any point of time. Okay, so like having some airway injury, airway edema, then hoarseness of voice, stridor, noisy breathing, gurgling sound when you have something in mouth, okay, some vomitus, blood, secretions. So these all are saying that airway is not right now is not right. So that means these are the criteria. If you get any of these, you will say airway is threatened or compromised, red. In yellow or green, airway is patent. Okay. SpO2 we don't keep usually in airway, we keep in breathing, but yes, just to give you a glimpse that usually they maintain SpO2. If airway is fine, airway is compromised, then likely you will get these things in problem. Coming to breathing and ventilation. So normal respiratory rate is good. If you are getting less than or more than the normal range, that is more than 24 or less than 10, red. Second parameter is, so respiratory rate is 1. Second is the saturation. In trauma, we take 94 and down is garbad hai. It is low. So it is red criteria. If somebody is having accessory muscle which is functioning, just by look you can say it's a compromised breathing. Okay, so accessory muscle use, gasping. Okay, just so this kind of activity, if it is happening, we see in any patient, this is gasping, it is impending cardiac arrest. Okay, so these are the statements where we can say based on the breathing assessment, these patients are red category patient. So just we are talking about the physiology. Okay, respiratory rate will be fine and saturation will be fine. They can be yellow, they can be green. Okay, based on other criteria. So right now we are just moving ahead with the physiology. So A, B. Coming to circulation, if the pulse is not palpable or BP is not recordable, no doubt about it, it is red. The benchmark for blood pressure is more than 90 systolic BP we take is good. Less than 90, definitely wrong, definitely problematic. Okay, so systolic BP less than 90, heart rate or pulse, normally it is 50 to 100, but more than 100, we are not going to label it as red. But yes, it will tell something is wrong there. So don't take just by pulse, we cannot say, we must have something more about it. Okay, but it will tell you that there is something wrong. Okay, so out of this, absent or feeble pulse, if you don't have the BP apparatus, then just by touching the pulse, you can understand that this patient is having sick. Capillary fill is very, very important. So pulse rate, capillary fill, and BP. So if capillary fill is more than 2 seconds, so there is a problem. But in green and red, green and yellow, the circulation is fine. Coming to D, so brain functions in disability. So we can know the brain functions by knowing the Glasgow Coma scale or score. And another one, very simple one, is ABPU. So alert, the person is talking, walking, talking, responding automatically, reflexly, is alert one. If you ask, then he will respond. अरे भैया क्या हुआ है? हैं? हाँ थोड़ा दिक्कत है. हाँ दर्द है. हाँ दर्द है. So when you are speaking to the patient, he is responding. So that is the next grade, verbal, responding to verbal stimuli. The third one is not responding even to the verbal stimuli. Then you go for painful stimuli. ये करते हैं ना बहुत लोग. ऐसे 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 ऐसे. यहाँ भी करते हैं ऐसे ऐसे. So we try to give some pain. कोई यहाँ पे ऐसे ऐसे करता है. So once you give pain, then he used to localize or do something. Some response is there. And the last one is unresponsive. This is a very, very simple tool to know whether he is alert or not. If the patient is not alert, you take him as red. Okay. If he is not alert, take him to red. That is the ideal way or simple way. Or if you are having the resources in yellow and otherwise, then you can take the verbal onward. So verbal and alert, green and yellow. So responding to painful stimuli, unresponsive, always red. Responding to painful stimuli, unresponsive, always red. GCS wise, if the GCS score is 13, 14, 15, so that is the mild traumatic brain injury. 8 or less is severe traumatic brain injury. So 8 or less, 100% severe traumatic brain injury, red. Even the moderate brain injury is taken in the red because they are having high likelihood of deteriorating, requiring some urgent intervention, cannot be delayed kind of things. So any score equal to or less than 12, you take in red. So airway, breathing, circulation, disability, ABCD protocol. Okay, ABCD protocol. For spine, airway with cervical spine, we go for single breath count. Single breath count. So if it is less than 20, we have to think that patient is having something wrong. If you get quadriparesis, okay, something is wrong, take it as red. So ABCD, ABCD, you just remember physiology we talked about, criteria for red, ABCD. In yellow and green, ABCD will be stable, normal. Okay. So coming to the relevance of injury. So many times the vital may be stable, but still the patient will have something which need to be addressed very immediately, that is red. So suppose a patient comes with this kind of mark. So see here, pulse rate is just at borderline. Okay, respiratory rate is fine, less than 24, more than 10. BP is fine. So based on these parameters, physiological parameters, we are going to label them as is not red, not red. Since he is having a history of four-wheeler driving, road traffic injury, so we may like to think about that. Let's do some investigation, try to know something. So not green, so likely it is yellow. But if you see a mark on the body, seatbelt mark, so based on this mark, that mark can be produced if you are riding on a very high speed, suddenly stop, then you will have that mark. So it suggests, the mark suggests that he is having high speed and sudden stoppage. That's why he is having the mark. So any sort of injury can happen inside. So that's why I am going to take them as a red based on these seatbelt marks. See, the physiology is normal, but still I am going to triage them as red because of this mark, which is highly showing that anything can happen inside. So red initially based on the physiology, Based on the parameter, it can be yellow, it can be green, it seems. But based on the injuries, we are going to mark them as red. So let's go through what kind of injuries, if you see, just by seeing the injury, even ABCD is fine, still you will make them as red. So in red lines, we have written what kind of injuries you should be marking as red. So see, all penetrating injury to head, neck, torso, groin. That means head, neck, chest, abdomen, and up to the pelvis, that is the groin. Anything penetrating here is red. Any kind of serious injury can happen because major vessels are there. So you see on left side masked patient, you see there is a puncture wound here. So this was a patient of gunshot injury came walking. Okay. This is stab injury, but he also came walking with full vitals. ABCD was normal. So ABCD is normal, but still based on the injuries, we are marking them as red. So all penetrating trauma starting from the hair to groin, that means head, neck, chest, abdomen, groin is red. Any major vascular injury, okay, any major vascular injury where you are thinking that limb or life is threatened. So even the limb is threatened, you have to make them red. Otherwise, he is going to lose the limb. Here you can see the color change on right side of the foot. You can see this color and this color. So there is a change. So likely, and you can see this getting some swelling also. Here the whole vessel is exposed on left side. Here you can see another one. So we are listening Dr. Boy here. See the chest wall movement. He is having a lot of abrasion over the chest. This is the flail chest. Okay, so flail chest. So you see the chest wall movement is different. So when inspiration, that segment is moving in a different way. So flail chest and lot of abrasion over the chest. So this was a run over case. Whole tire went ahead through his body. Okay, you can see the tire mark here. Similarly, if you have neck injuries like mark, a strangulation mark, major one of face and neck, upper chest. Okay, so some swelling in the neck. So some penetrating trauma to neck. These all are red Triage categories. Okay. Major musculoskeletal injuries like you have both femurs gone. We see in railway track injuries. Okay, or even runovers. So major musculoskeletal injuries, pelvic injuries, these all we are going to keep them as red. Okay. Any amputated part is coming, that you have to fix the amputated parts. That's why we try them also red. Now coming to yellow categories, that when ABCD is normal, but if you have fracture of distal areas like below the elbow, below the knee, that we call they will lose less amount of blood. So that's why we label them as yellow. Okay, because we have to investigate, we have to see. Many patients used to come with normal GCS and we are having a doubt of head injury. So if the patient is having full score, but history of loss of consciousness, vomiting, some ENT bleed, so there we are going to have CT scan of head, NCCT head. That means usko yellow karna padega, that we have to do yellow. If somebody is having alcohol influence or intoxication, so again, you cannot know whether his GCS is real GCS or that GCS. So in that doubt, again, you have to do GCS. So even if the patient is having full GCS, the score is 15 out of 15, but still we have to do the CT scan. Okay, like a patient is having on anticoagulant, old age patient, old age patient with some raccoon eyes, battle sign, some mark here, behind the ear. So these are battle sign. CS is coming out. GCS is full. So CSF otorrhea, CSF rhinorrhea. So these are the signs where you are going to get a NCCT head. So once you are going for any investigation, we told that you have to level as yellow, not green. Yellow. Okay. Okay. How we know that CSF is coming with the ear bleed or nasal bleed? Any idea? How you can test bedside that CSF is coming? Yes, I am just hello ring. Who told? Sandhya. Very good. Excellent. So once you take a gauze piece and just pour some drop over it, ask him. So if CSF is there, so blood is in center and the CSF will create a halo sign. Okay. Yes. Very good, Dirga Devi madam. Very good. Thank you. So that is how we test bedside. Halo sign. Very good. So these are the criteria for yellow. Now coming to green, as we discussed, mild things where you don't require any investigation, you don't require any observation. You think we can safely send them back home after some sort of medication, management, small procedures. That is fine. That they are green. Okay. So let's take a case scenario once more. So 31-year-old male, four-wheeler, rider, driver, road traffic injury presenting to you. Pulse rate is just upper border, like same patient we are talking about, which we just talked previously, the seatbelt mark person. Okay. So if we consider the physiology, based on physiology, his tries may be yellow, maybe green, based on physiology. If we talk about injury, then based on injury, we are going to mark them as red. Okay. Mark them as red. Now coming to the third. So on examination, ABCD is normal and there is no obvious clear-cut injury. No obvious clear-cut injury. आपने बहुत बार देखा होगा. Sunny Deol is jumping from third floor, nothing, and उसके बाद वो दौड़ने लगता है. You must have seen, गोली चल रही है, उसके बाद ऐसे कर रहा है, उसको डंडा लग गया, ये हो गया, उसका ऐसे गोली को रोक लिया, कोई इंजुरी नहीं है. ABCD is fine, everything is fine, no external injury. So based on the mechanism, how he got or for what he came for to the emergency, if we ask that mechanism, what was the event which happened, then we can still gauge out that something serious is possible, yes or no. See, the third way to triage, first was the physiology, and in physiology there was a quick way and detailed ABCD. Then we had the injuries. After examining the patient, we got certain injuries penetrating anything from here to here. We went ahead with the chest injuries, open chest wound, flail chest, abrasion over the chest, okay, flail segment, major bone injury, major musculoskeletal injuries, vascular injuries. So this based on the examination, whatever injuries we were finding, we labeled them as red or yellow or green. So that was the criteria. So physiology, injuries, and now coming to mechanism. So again, the same patient we are seeing. So crying, asking, and saying, now he is telling कि उसका co-passenger जो था, he was received broad dead. So two person used to came to your emergency. One is broad dead, other is having everything fine, physiology is fine, talking, walking, no external injury, but he is just giving a mechanism that we met with the accident where my one passenger, co-passenger died. So just by listening that if the co-passenger is dead, that means that the impact was so high, that somebody died in that impact. So if the co-passenger is dead, that means it is red. Remember, everything is normal, ABCD is normal, no injury, but one passenger who was sitting next to him died. Red. Just remember, usually we miss in emergency department these things. So this is the third safety layer. Physiology, injury, and now the third. Okay. mechanism. Now coming to the next one. So based on physiology, maybe green, maybe yellow, based on injuries, just abrasion over the hand and leg. Again, nothing like red. It is going to be green. But once we go with the mechanism, then we have to take them as red. Okay. Overall idea is that the mechanism suggests how much impact has happened. Even right now, everything is fine, but more likely they will have something wrong inside. That's why we take care of mechanism of injury. So various types of mechanism can be road traffic injury, fall, assaults, railway track injury, blast injury, burns, special considerations. So these are the points. When you ask history, you have to ask in detail about these things. So let's see what kind of factors which affect in road traffic injuries. So if you see the force and energy, so suppose if somebody is hit by a bus, hit by a lorry, hit by a van, so the size of the vehicle which hit this is so big that anything is possible. So it is better that make them as a red. Evaluate properly. If everything is fine, observe some time and then just retrace them as yellow and observe there, because the incident was like that. Speed on which you were driving, whether using the protective gears, yes or no. Helmet was there, yes or no. Seat belt was on, yes or no. So anything you are riding more than 30 kilometers per hour, it can produce any kind of injury. So whenever a bicycle, this two-wheeler rider used to come, आप उससे पूछो आपका स्पीड कितना था, हेलमेट था क्या आपने पहना हुआ. ऐसा तो नहीं कि हेलमेट को हाथ में लगाया हुआ था. बहुत लोग ऐसे हाथ में लगा के हेलमेट को और बाइक राइड करते होते हैं. हेलमेट यहाँ होता है, यहाँ नहीं होता है. They don't understand कि helmet is to safeguard you, not your hand. Anyway, so if somebody got hit and he was stuck inside the vehicle for more than 20 minutes, co-passenger is dead. Okay, the vehicle got fired, stuck there. So inhalational injury is a high chance they will get the ingestional injuries. So these are the criteria by which we label them as red triage, especially in road traffic injuries. Okay. Now, when you are examining these patients, based on the impact, you should be thinking what can have happened. Like a steering wheel, you can see everything is fine. You are not getting any mark or something, but still the force transmitted can create rupture of thoracic aorta, pneumothorax, diaphragmatic rupture. Okay. So these all are possible. Cervical spine injuries, like movement like this, can lead to cervical and spine injuries. So just to suspect what kind of injury you are suspecting, like if somebody is hitting from back, some car is being hit from back, then suddenly his head will go like this and it will hit to the windscreen and again go back. So multiple to and fro movement, whiplash injury, see spine injury is very high, head injury is high, facial injuries is high, okay, and bones will break. So just to tell you that the mechanism can allow you to suspect what you need to suspect. Okay. So just go through this, what kind of injuries you are going to have, so that you can suspect, you can investigate properly. Okay. So mechanism is very, very important. If you are, so just go in detail. So so these are just to tell you that if somebody is falling from height, then if you are having calcaneum fracture, so there is high chance that the spines will get fracture and paraplegia can happen. Okay, coming to assaults, same thing can be possible. You just have to examine completely. Like many times they come walking, हम पूछते नहीं, हमें लगता है कि assault ही तो है, क्या है? But we don't know that whole, like you can see, this is a picture, postmortem picture of a person. So see, lot of contusions are there, lot of blood loss in the subcutaneous plane. Externally, skin is not breached. You can have a scalp injuries, very common, and can bleed a lot. Okay, so just you have to examine wisely. Don't give green in hurry. Most of the time, this fighting people, we label them as green, and then maybe like this. So you have to examine thoroughly. You have to look and just consider that it can be railway track injuries. Always it is a high velocity, very high load, mostly fatal. So once they come as railway track injury, you have to label as red. Blast injury is always remember that blast is one complex injury where multiple ways to injure you can happen. So overpressure, blast waves coming, heat is coming, burn can happen, the fragments can come. So primary impact, then secondary impact fragments can penetrate anything. Tertiary impact, that due to the blast wind, you are thrown away. You are thrown away. So all sort of injuries can happen. All sort of injuries can happen in blast. So always any blast injury patient, we label them as red. Burns again. If you are suspecting inhalational burn, airway can be a problem. So then we will go for this red criteria. Otherwise, based on the 9% rule or one palm rule, so anything more than 10% requires hospitalization. So we are not going to make them like face, eyes, hand, perineum, axilla. These are the very vital areas. So we consider and give them higher triage. Yes, can you see my slides? Sorry, it got disconnected.
Yes, sir. It is there.
Okay. Special cases, pediatric, pregnancy, geriatric. Again, these are special considerations. So don't give them as green. Never. What we do in day-to-day practice, we label them as red most of the time so that we can prioritize not for the mechanism or injuries, but for the privacy they require, like sexual abuse patients, child abuse patients, the kids, they require more attention. So it is better to prioritize higher. If you are thinking green, give them as yellow. All sexual assault, we don't keep them as yellow or green because बहुत भीड़ में जाएंगे वो, there is a problem, legal issues. That's why we keep in a separated red area where you can closely monitor them and do the needful. Okay, so you can see the scenario. So based on mechanism of injury, like we were talking about earlier, so mechanism we are going to take according decisions. So based on physiology, it was not red, it can be yellow, can be green. But based on injuries, we were thinking the abrasion, very small things are there, so it may be green. But once we came to know that mechanism, then we decided that we should make them as red. So that is how we have to utilize various ways to do the triage. Okay. So what we will do, we will share the trauma triage form of ours with you. So Rupa or any person from our collaborating center, if you are having the trauma triage protocol, can we send in the group if possible right now?
Okay, sir.
So
I'm
triage
sending,
form,
sir.
it will be better so that you just keep with you. wherever you have first interaction with the patients, so just by seeing the criteria, you just start practicing triage. See the form, find out the criteria, but the usual approach is once somebody is coming, ask the name. If you ask the name, he can vocalize, then right now not read just by this much information. Then you go for vital signs assessment. Then you go for examination findings, that is injuries. Then you go for mechanism of injuries. So try to practice whatever best you can practice. Even I will say that just by visualization, if somebody is coming both legs chopped off, just by look I can say he's red. If somebody is coming with a stab knife here, just by look or just by he said कि सर गोली लग गया इसको छाती में, गोली लग गया पेट में. So penetrating trauma torso, I am not going to take vitals and detail at the triage point. I will just say he's red. But if everything looks fine, आपका first look पे 10-second assessment पे, then you go for full vital signs ABCD. Once still everything is fine, that means you can spend some more time. Then you go for assessing the injuries, basic injuries, and then the mechanism. So this is how we do triage for trauma patient in day-to-day practice. Now for non-trauma, the same applies. ABCD is same. ABCD is same. In injury part, injuries identify, you go for clinical assessment of the patient, like a patient who is coming with pain abdomen, and you are seeing that generalized rigidity is there in abdomen, so perforation peritonitis. A patient is coming with a history of fever and you are seeing the swollen limb, so now you are suspecting DVT. So you can think, so same kind of examination can be applied to non-trauma even. Okay, a patient who was coming from China and having cough. So during COVID, what we did? Just by history, he is coming from China. He was labeled as a bigger triage of COVID. So that is how we can utilize this trauma triage to non-trauma also. Some of the things are very, very high priority or time sensitive. So even in red, if you have 2-3 reds, we give further priority to them. So we call them as fast track. Like any chest pain on left side, chest pain more than 20 minutes, suspected of MI, fast track, don't stop, fast track. Even in red, he will get further priority. Cardiac arrest patient, non-responsive, no carotid, highest priority. Stroke patient, high priority, fast track. So some of these are the fast track patients where even if you have 2-3 reds, prioritize them and give the further priority, we call them as fast track. So this was how we go ahead with triaging. So I am not going in these details of quality assurance. Let's just initiate a triage at our place. If you are doing already, you just go through the forms. You just print one and paste on the table or somewhere so that you can utilize. What you can do, you can start writing on corner of the page of the patient, red, yellow, green. If you have green color pen, red color pen, you start using that. If you have triage band, nothing like it. So even if you don't have bands or those kind of things, still you can do. And try to maintain a log or a small register at triage desk. So let's start doing triage. It is not that somewhere you start and maybe one day you will reach the full scale triage system at your place. Okay, so I am not going in detail of this quality assurance, but let's come back so to the post test. But before that, I will say that this is the time you can post your questions. So we'll take few questions here, and then we'll post some questions here. So Rupa, I will seek your help. So if you find a question, then we can just answer, and then at the end we are just about to reach our timeline.
Ji.
So
Yes, sir. So there's a few questions I really wanted to.
please.
Yeah. Yes. Sir. So one question was how that this triage is different from the disaster triage, sir. That first of all, before sir will start, I really wanted to tell you, ma'am and sir, that on Monday we are going to take that triage at disaster session. So over to you,
So,
sir. By the time.
not disaster. I will tell on that day categorically the difference between a large scale disaster and mass casualty. Okay. So see, largely the disaster triage we utilize at the point of happening. We often call them as field triage. So like we are in war zone, lot of injured patients are there. So we will do some categorization there at the site itself. Okay. Like you have earthquake. So at the place of earthquake, like in Nepal earthquake, so at those zones where the earthquake has hit large number of people, we categorize them. Whom to give treatment first, whom to give later, whom to shift in ambulance first. So that is a field triage. So largely the disaster triage is meant by that only. So there are various kind of triages are there. Like we have the start triage, jump start triage, this save triage. So many more are there. Okay, for disasters. This triage is being utilized when you are working in day-to-day practice in your emergency department. So even in emergency department, you have limited number and patients are more. So to match the demand timely and give the care to the best person, okay, best possible way, again we categorize. So this is emergency department triage, not the disaster triage. So in disaster, the principle is do the greatest good for greatest number. Okay, do the good for those who requires minimum things, and you can say more number. So greatest good for greatest number is the ethos of disaster, but here do best for each. That is the idea. So that is disaster triage. And this I taught or discussed was the triage which we use in emergency department. So let's come back. Any other question, Rupa? Any other question?
So, yeah. So one question is, sir, family member dead due to this syncopal attack. Even vitals are normal. Management, please. Sorry. Shanta Kumari ma'am, can I request you to rewrite your question? Could you able to, sir, comprehend the question, sir?
If somebody has died and the other family member is having normal vital, then see that patient. No, we talked about the impact of injury. Suppose I am traveling in a car. So कोई बस या कार हिट करेगा और एक पर्सन कार के अंदर का डेड हो गया, one person has died inside the car, then high likely वो energy transfer could have happened to me also, even if I am normal. Even if I am normal. Okay. So that's why it is being tried. But if somebody is died of heart attack, so we are not going to try the relative as read. It is, so it is, the problem was with the individual, syncope is with the individual. But if we talk about road traffic injury, then whosoever was sitting inside, they all can have the transfer of energy. Okay. So that's why we are not going to label them. Any other question?
Yes, sir. So, sir, I have seen few questions on which guidelines. So, I think you have to talk a little bit more about this AIMS trauma protocol. And by the time I have shared that operational guidelines with them, all of them.
See, I will say that go with the operational guideline with Ministry of Health that we prepared as a group. Okay, there is a Triage protocol given for adults, given for pediatrics. Okay, trauma, non-trauma, both protocols are inside in single page. So you can just take a printout of that, paste there. Okay, so okay, so utilize them. Let's utilize them. Those who want to establish a triage system at their place, you may contact our colleague Rupa ma'am or other colleagues at WHO Collaborative Center. They will help you. We have Triage implementation guide. We have Triage modules. Another thing, many more things are there already. So you can utilize them all. Okay, so can we go back to our post test? So take out that plain paper. Take out that plain paper again where you marked the pre-test. Now we are going to mark the post-test. Okay, so what do you mean by triage? Okay, so that's fine. Okay, next question. Okay, triage based on, just mark in front of that 1, 2, 3, 4. You marked already pre, and now we are marking as post. Question number 3. Question number 4. Don't mark on the slide, please. Okay, black triage. Who can do triage? Question number 7. Triage is based on physiology, injuries, mechanism, all of the above. Question number 8. Which patient is triage as red? Most specific injury in back impact. That means the vehicle has hit from backside. So what kind of injury you suspect? Whiplash means the head is banging like this. So that we call as whiplash injury. Dangerous injuries can occur when a person has fallen from this. We don't discuss. Right? So if somebody is fallen from more than 3 times the height, then anything can be possible. Some book says more than 2 times, but definitely if it is more than second floor or above, just remember second floor or above, one floor is 10 feet at least. So second floor or above, red criteria. Anything can happen. So just mark the correct answer. So let's check our answers, pre and post both. So आप खुद ही उसको just cross or tick and then tell pre post में difference is there, how much pre and how much post out of 10. So triage means now we all know to sort out, categorize based on severity of injury or illness. So right answer for 2 is A. Right answer for 1 is C. Triage system was practiced first time. We talked about the battlefield 1800. So that is started from the war time very early. Okay. So B, answer is B. The goal of triage in emergency department is to provide the most effective care for the greatest number of patients, to provide the best care to each individual, to dispose the patient early, all of the above. See, in ED, in day-to-day practice, we try to give best care to each individual. In disaster, it is different. But the right answer for ED triage is, answer is B, do the best care to each individual. Black triage, so those who are dead, clear-cut dead, mutilated, or having no head. So D is the right answer. Okay, so 5, black triage, beheaded, D. Who can do the triage? Anyone. But we are very much sure that in coming time, we will see all our bright nurses doing the triage, because this is one of the critical things which nurses should do, and globally, this is in practice that nurses are doing. Okay. So answer right now is all of the above. If somebody has marked as nurses, they are also right. Okay. Trauma triage is based on, so now it is all. You have to check the physiology, injuries also, mechanism also. Which patient will be triaged as red? So all penetrating head, neck, torso, up to groin. So choice number A is the right answer. Open or close fracture of hand and feet, very small. So you can try yellow. Isolated long bone fracture, try yellow. Question number 9, back impact. So some vehicle is hit from back. So the head will move like this and hit multiple times back and forth. So we call it as whiplash injury, where cervical spine, head injury, these all are possible. So whiplash injury. And this we talked, dangerous injuries. Okay. So triple the height is the right answer. Number 10. So now just message in the group that what was your pre and what was your post. Just message in the group, pre and post. Okay, let us check pre and post. Exciting. How much marks in pre and how much marks in post? Yes, Brinda, very good. 8 to 10, 8, 10, 4, 9. Great jump. 9 to 10, 5 to 8, 7 to 8, 7, 9. Very good. 7, 9. 6, 9, 6, 9, 7, 9. Very good. Very good. 7 to 10, 6 to 10. Great jump. 5 to 8, 7 to 10, 7 to 10, 7 to 9, pre 7, post 6 to 8, 8 to 8. Okay. So I'm seeing many of you have got 10 out of 10. Geeta R. Great. Okay. You're a master trainer. Geeta. Very good. So 7, 10, 10, 9, 10. Post is 9. Very good. Very good. 5, 9. Excellent. 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 Oh, many of you are the full marks people. Okay. 100 out of 100 kind of. 10 out of 10. Very good. So many of you. So many of you. Very happy. Sonam, great. Supriya, great. Very good. Pavanji, very good. 10 in post test. Okay, so you got your results out also. So, so this was all for today. So we learned today about the day-to-day practice of triage. So I told we go for major 3 categories, red, yellow, and green. Anything where you feel the limb, life, or organ is threatened. So life, organ, limb is threatened is red. Anything or any kind of patient where you think that little things and discharge, no need to keep, no need to observe, nothing wrong can happen to these patients is green. If you have any doubt or something you want to observe, investigate, or do anything both, it is yellow. A broad statement is whenever you have doubt in day-to-day practice, whenever you have a doubt, give higher triage. Don't do under triage. And let me tell you, up to 25% of over triage is acceptable globally. That means some patient was having, I can give some green also or yellow also. Yellow also or red also. So I am having a doubt. I can give red also or I can go for yellow. So I have chosen red. Green, yellow, I have chosen yellow. Higher triage. So up to 25%, that means in 100 patients, triage, you given over triage or higher triage category, 25 is acceptable. But under triage is dangerous. So if you have doubt of red versus yellow, if you will keep in yellow, this is dangerous for the patient. So go for higher triage whenever you are in doubt. Okay, so that is the broad statement. And for doing the triage, we utilize 3 ways. One is physiology, one is mechanism of injury, and third is the injuries, whatever you see. So physiology, injuries identified, and mechanism. Very simple is when the patient is coming, just have a look. Just have a look, ask, go for quick assessment, 10-second assessment. And if everything is fine, then you go for vital sign checking ABCD. Still fine, then you go for examination. Still fine, then you go for this. It will not take more than 2 minutes. If the patient is sick, you can simply identify. It will not take more than 30 seconds. Okay. Start this practice just by implementing triage system, you can save 30% of lives. So impactful. So triage is one system where low cost or no cost and high impact. This was all for today. So thank you very much for joining a large number, and I hope I was able to make some understanding about the triage. And I will get great news from all of you that you started or strengthen your triage system, whatever you are having. So hoping in coming time we will have great changes at any hospital wherever you are working. So thank you very much for joining us. Over to you, Rupa, for last words.
Thank you very much, sir. It was really wonderful, and I can see those things on the comments also. Thank you very much, sir and ma'am. Sunil sir wrote that today he learned the actual triage. So एक चीज मैं कहना चाहूंगी as a nurse, my dear friends, sir and ma'am, you don't need a triage counter. You don't need a whole system to start triage. Triage is a nursing basic responsibility. It just means initial assessment as soon as you meet the patient. And in emergency, we cannot wait. So the thing is that triage is when you meet patient, when you assess the patient, do it in this systematic way and start writing. Once you will start writing, soon you will see that whole system will be created. So, sometimes we are privileged to have the system, but sometimes we nurses can create the system. And I know you all can do that. So I hope whenever, wherever you will be in emergency, whenever you are meeting with the patient doing the first assessment, you will be definitely writing red, yellow, green based on their categories and other important details. With that, I really wanted to thank from bottom of my heart. Thank you very much, sir, for taking such a interesting sessions, and lovely that you all attempted pre-test and post-test. Again, I wanted to say same. I hope these sessions are helping you to upgrade yourself. And please don't always see your knowledge validating with the certificate, because at WHO said we are very clear when we will be providing the certificate. We have a proper structure to providing the certificate. Soon we will be launching it as a course. Then you will be definitely getting the certificate. But these are the online series for seeing the national emergency, and we know that you all need it. So Monday, the same time 6 p.m. we will be again uniting, and we will be learning more about triage at mass casualty. Over. Thank you. Would you like to say last few words, sir, if you have any? Thank you. So bye bye everyone, see you on Monday. Thank you very much.